Refer to standard best practices for procedural setup, including placement of guide wire in the left ventricle and pigtail catheter in the bottom of the non-coronary cusp. With flash ports oriented at 3 o'clock to promote commissure alignment and the inline sheath fully forward, load the delivery system onto the guide wire and insert into the patient. Carefully cross the arch according to transfemoral best practices and move to the predetermined view with left and right coronary cusps overlapping. The cusp overlap technique helps drive precision by isolating the non-coronary cusp to provide an accurate anatomical view for assessing implant depth. Position the catheter marker band at the midpoint of pigtail catheter. Verify pigtail placement with hand injection of contrast. Approaching target depth from a supraannular level provides greater control of implant depth to minimize the risk of interaction with structures of the conduction system. Slowly deploy the valve until the marker band reaches the third node of frame. Use controlled, small movements to facilitate slow deployment, allowing the valve to descend to the target depth of 3 millimeters. At this point, consider pacing to help increase valve stability. Start pacing prior to annular contact, starting at 120 beats per minute, and adjust considering individual patient factors to achieve desired pressure. Rapidly deploy from annular contact until just prior to the point of no recapture, as the unexpanded bioprosthesis temporarily obstructs cardiac output. Discontinue pacing immediately before reaching the point of no recapture. Assess valve position of the non-coronary cusp while in the cusp overlap view. Move to a 3-cusp coplanar view and then roll LAO until the aortic arch is open and parallax at the inflow is minimized. Remove any remaining parallax by moving caudal. Assess valve depth at the left coronary cusp in this view. After confirming valve position and performance, release system tension, apply forward pressure to centralize the delivery system, and pull guide wire back from the apex. Remove the pigtail from the non-coronary cusp and very slowly deploy as the outflow region leaves the capsule and paddles release. Standardization of the Evolute procedure through precise anatomical views and controlled deployment using the cusp overlap technique is intended to deliver consistent, excellent outcomes and improve the TAVI experience.